Good morning, ladies and gentlemen. We are just about to start our live and on-demand webinar discussion with Point B and Baystate Health. We're going to allow people to sign in. We see people coming online now. We'll get started in just a moment. Okay, why don't we get started and we can allow those who join us in the coming minutes to catch up with us as we move forward. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium, and I want to welcome you to today's live and on-demand webinar session with Baystate Health and Point B. First, I'm proud to say that with Baystate Health and Point B, we have two MHTC members presenting to us today, which is always exciting, especially when we get to see how those of us who advise, consult, and provide services to healthcare actually work closely with healthcare organizations. And what we can accomplish together is always a very informative and useful discussion for those who are dealing with the issues that we deal with today in healthcare, especially, and I can't say post-COVID, but I can say late COVID, hopefully. We'll see how things move. First, I'm very pleased to welcome Dr. Doug Salvador, who's the Senior Vice President and Chief Quality Officer for Baystate Health. Additionally, Doug serves as the Chief Medical Officer for Baystate Medical Center and is an associate professor with Baystate's Massachusetts UMass Medical School partnership. Baystate is an academically centered health system, and as such has more than just the patient care challenges, but the challenges of teaching and research, which have been stretched and tested over the course of the last several years. And we're delighted to have Doug join us today. Also joining us is Lainie Conley, a healthcare principal with Point B, who in partnership with Baystate Health has worked closely to improve patient safety and clinical quality with a tight collaboration between the clinical and administrative members of the organization. This is an ongoing journey. This isn't a destination. And we recognize the challenges that this kind of patient care improvement brings to us when we are in a post-pandemic period. Let me provide members of our audience a little bit of sort of rules of order for today. We're going to ask that you submit your questions by typing them into the question pane or the chat button at the bottom of your screen. We will respond to you during the presentation if your comments are particularly pertinent and relevant at that point in time, or we have time reserved during the presentation to take everyone's questions. And we'll be following your questions. Janice Karen, my colleague, will be keeping a close eye on the chat to determine whether or not questions are coming through and helping to curate those questions so we can get them all answered. We'll have a couple of audience poll questions. Please respond to those as they come on your screen. And at the very end of the presentation, we have like a 30-second presentation or 30-second poll or survey that we want you to complete for us to tell us how well we did. We put a lot into our webinars, into our podcasts and video casts, and we're looking for your input on how well we're doing that. You can also participate and share what you experience on social media. You can see our handles at @MaHealthData, @PointB, @Baystate_Health, and @MHDC event. So feel free to tweet or use the social media platform of your preference if you're so inclined. Thank you for that. Why don't we move to the next slide? All right, I'm going to stop talking and taking up too much of our presentation's time. And I'm delighted to turn our discussion over to our colleagues, members, and friends at Baystate and at Point B. Lainie, Doug, perhaps you can provide us a bit more of an introduction, and we will be waiting eagerly to hear your presentation.
Doug, why don't you go ahead and lead? Or I can, if that's easy.
Please go ahead.
Okay. Yeah, no worries, no worries. Well, hello, everyone. Thank you. We are very excited to share this small part of our journey that we've been on, attempting to improve safety and quality using a daily management system. And so, as Dan introduced, my name is Lainie Conley. I work with Point B and have been in the healthcare industry for many years, working diligently with all of us, trying to get our patient quality and safety to a better place. So again, very happy to be here.
It's a pleasure to be here with both of you, Denny and Lainie, and thanks for those who are watching live and on demand. As was mentioned, my name is Doug Salvador. I've been doing physician leadership of quality and patient safety for about the last 20 years. My background is as an infectious disease doc, and I'm excited to chat with you, Lainie, about the work that's going on at Baystate.
Excellent. I think we can go to the next slide. So of course, the purpose and intent of this time together is to explain what a daily management system is and how it increases the reliability of patient care, and then share an example of how our IT team and leaders came together with operational leaders to help us create a process and system, a framework that allows the frontline teams to actually take steps every day to improve the care that they are giving, because they're the closest to the care. They know what they need to do. And so the interaction between operations and IT with this work has been really fun, and we can't wait to share. Doug, would you add anything on that?
Not on the purpose and intent. I think it may be time to kind of lay some context of why we're having this discussion about patient safety today. I think no surprise to any of the attendees who work in healthcare delivery systems or are healthcare providers that the patient safety report card for the country is mixed. A recent study looked at publicly reported hospital safety metrics in the decade leading up to the pandemic and reported significant improvements. Unfortunately, the pandemic erased many of those gains. Some of the headlines included increases in population rates of heart disease and stroke between 2019 and 2021 after decades of declines. There were also dramatic increases in healthcare-associated infections in hospitals across the U.S. in the first year of the pandemic, and then a disheartening additional increase in the second year. National databases of culture of safety surveys of healthcare workers showed dramatic decreases in perceptions of teamwork, team communication, and psychological safety, which correlate very closely with worse patient safety outcomes. So we're reeling a bit as an industry, and just to give you an indication of the attention being paid on this now, the U.S. Department of Health and Human Services, AHRQ, CDC, CMS, and the FDA announced just this week that on November 14th, HHS Secretary Xavier Becerra will convene a listening session on protecting patient safety and healthcare worker safety across the country. So it's a big topic of conversation with a lot of folks in healthcare, trying to figure out how do we get back to the levels of patient safety risk from before the pandemic, and how do we move beyond.
Thanks, Doug. That it's sobering for sure. So we have been working in healthcare for many years on this, and given the pandemic did throw us for a loop, but why do you think we consistently miss targets when we talk about safety and quality in healthcare?
Well, we talked a lot during the pandemic about the stress of the pandemic on the healthcare system, really uncovering weaknesses that existed all along. So historically, accountability for quality and safety in hospitals and ambulatory clinics has been on the shoulders of directors and managers. It really needs to include everyone taking care of patients and reach all the way down to the front line. If we're going to improve, it'll be with the daily activities and the care team that provides those one-on-one interactions with patients. I say to people all the time, the hallmark of quality care is doing the little things every day on every shift for every patient. And that's really why DMS is a powerful tool for reaching higher reliability. It gives visibility on whether those little things are done for patients, and it can give teams a rapid signal for action when they're not done.
Yes, Doug, I really appreciate that because I have found being in healthcare, the frontline team solves the same exact problem every day, and that there's not a way, or hasn't been a way, for them to raise their hand and say, I'm out again. I don't have this stock, this supply again, or again, this refrigerator has broken again. This is how we go to fix it. So the daily management system does offer the opportunity for frontline staff to raise their hand, report, and get attention to the things that prevent them from bringing great safety and quality to themselves as well as to patients. So I appreciate what you're saying, that over time, it's always been on the shoulders of the leaders to take care of safety. And now we're realizing, it's a team effort. We got to get the front line connected all the way up the chain. So thanks on that. Maybe I should cover a couple of points of what DMS includes.
Great.
Now, I also have a question that we might want to take a moment to look at, which is, are there specific types of safety decreases? Was it worse in particular care settings or for particular types of care? Did you notice, Doug and Lainie, that the pandemic post surge, did we see specific types of decreases in safety and quality, and were they unique to care settings, unique to particular types of care?
So they ran the gamut, unfortunately, of sites of care. And I think a lot of that had to do with access initially, immediately in the pandemic, because of closing down certain services. So for example, there were many colorectal cancer screenings missed in this country in the first year of the pandemic. And some of that was a fear of going outside of your house and getting COVID, but some of it was healthcare workers redeployed to take care of sick patients in the hospital as opposed to doing elective colorectal cancer screening procedures like colonoscopy. And similarly, when patients stopped going to routine primary care visits, there were fewer pap smears and fewer mammograms being done. And that is a looming concern, because many of those have not been caught up on. And there's a concern that people are going to present over the next several years with more advanced cancers with worse outcomes because of that lack of access. We see similar lack of access now for different reasons, right? People are not necessarily afraid of going to the doctor's office, but because there's been such a migration in the workforce away from healthcare, there are fewer staff and fewer people around to see all the folks who need care in an ambulatory setting. On the inpatient side, the stresses to hospitals have been profound, and they relate to really an increased demand and an overcapacity. And when hospitals reach that overcapacity situation, there's some nice studies that were done looking at mortality rates for patients with COVID in hospitals, comparing those that were at a census overcapacity versus normal capacity. And we saw that the mortality rates were worse when hospitals were extremely stressed. And I think what you're seeing now in the headlines this week is the pediatric hospital system stretched beyond what we've ever seen before. Again, for different reasons. It's not COVID, it's other respiratory viruses. But again, that carries with it increases in patient safety risk that are hard to overcome.
Thank you.
Yeah, great question, Danny. I appreciate that because the clarification, it does help. So then let's move to the next slide. I'm sure many folks are familiar with what daily management system is. It's actually in many industries. It's not just healthcare. Healthcare is a bit late to the game, actually, when it comes to DMS. And there are many hospital systems and organizations across the US that have active DMS systems. The interesting thing about DMS is it's a cultural fit. It depends on the organization, which pieces of daily management you decide to put in place and where you're trying to leverage the strengths of your team and what you'll be able to implement and get the biggest bang for your buck for the effort put in. So as we said earlier, a daily management system is a structure by which organizations conduct operational management to ensure the day-to-day goes as planned and continuously improves. And then there's parts to daily management system. There are tiered huddles, leader standard work, improvement rounds, strategy deployment, metrics, standard work with process confirmation, and then A3 and Plan, Do, Check, Act, or PDCA, PDSA, and the problem solving aspect of DMS. There are other names and ice cream flavors that go into DMS. But at the basis, this is usually what we look for when we implement a DMS system. It does take a long time. There's no part, I don't think, of DMS that is easy. As soon as you start in on any one of these aspects, you do see results quickly. Usually staff engagement comes up pretty quick. So that's one of the reasons why I enjoy doing DMS, is because the staff engagement, the morale of the team, because you're listening to them, you're with them, comes right up. So I know at Baystate, Doug, you guys decided to start with tiered huddles. So what has been your experience?
So our focus from the beginning was on safety. And we wanted to do exactly what you described. We wanted to create a tiered huddle system that allows escalations to happen. So communication is a key imperative in reliability and in safety. So it was the ability to have conversations and communication up and down through the organization that was really facilitated by the tiered huddle system. So we have a frontline huddle, we call it Tier 1 huddle, that happens at individual unit levels, led by individual unit leaders, such as a charge nurse or assistant nurse manager on a hospital unit. And really, you start the day by asking, what happened overnight on the last shift that we need to know about? What is going to keep us from being able to take excellent care of our patients today? And create some situational awareness. And so what we ask team members to do at any point during the day is to go to our huddle board and write down those things that are getting in the way of taking great care of patients. And then also an opportunity at the huddle for people to just call them out if they didn't get a chance to write them. And there's a scribe to sort of put them up there. This all relates to an accountability for taking those things that people raise and making sure that they get solved, right? As you talked about at the beginning, Lainie, healthcare is riddled with people who, in a chaotic environment with lots of pressures and immediacy on tasks, sort of step over those speed bumps in the road and don't go back and fix them. So that's really what the initial Tier 1 is intended to do. And we've seen just what you described. We've seen that engagement, people really pleased that someone's listening to the things they're getting in the way, whether it's a computer on wheels that is not working for them correctly, or a supply in the supply closet that's either missing or the old version and it needs to be updated to the new. And then when they call out things at that Tier 1 huddle that they can't solve on their own, then they have a place to go with it. They escalate it to the Tier 2 huddle, and then a different set of leaders, in this case, the director and the managers for multiple units, will get together and they'll have their own accountability board, if you will, where those things are brought up. And similarly, for things they can't solve or things that they notice are a pattern and not just happening in one area or another, they have a place to take it, which is the tier 3. Each hospital in the system has a tier 3 huddle currently, and we expect to have tier 3 huddles as we roll this out beyond just the hospitals in each of the clinical care or provider entities in the system.
Yeah, that makes great sense. And it sounds so easy. We have a tier 1 that goes to a tier 2, that goes to a tier 3. So simple, but I have found in other healthcare organizations that the problem solving is the hardest part. So learning what is able to be solved at the tier 1 level by that level of staff, and then what needs to go to tier 2 and tier 3 and up the chain. And the ability to problem solve, to understand what the problem really is. I've seen hospitals are challenged by that. What have you seen when it comes to problem solving?
So I think that's a great time for me to sort of say, look, if you want to be successful at this, you need to have experts in your organization. And we're incredibly fortunate at Baystate. We have an operations excellence team that is filled with talented, passionate, fantastic folks who really understand this. It's led by Lisa Demko, our Vice President of Operations Excellence, who's taught me so much as we've moved along with this. And so much of this depends on the leaders and the staff being open and willing to learning new skills. We talk about one of the things that teams have to do early on is be able to standardize a process. So I think about the maturity or the evolution of this system as you grab people, the engagement happens early because at those tiered huddles, they're able to voice, and there's visibility and accountability for, again, taking away the things that are getting in the way of them delivering safe, excellent care.
Mm-hmm.
The other thing that grabs folks is we highlight good catches and great things that people do to keep people safe. And then the next step in this is really, can you standardize a process? When you find that something's not being done correctly, when someone calls out an issue, can you then take that and do the problem solving that you described and standardize a process? And the reality is we're not so good at that in healthcare, and that requires a different mindset. It requires, instead of saying, well, this is a busy unit, we see a lot of patients, we get it right most of the time. It requires a team and a leader to say, look, we want to get it right every time for every patient. And that requires a different level of sort of understanding of the problem, understanding of the root causes, and an ability to manage change and inspire everyone to want to get it right every time. And that's, to me, the next level of maturity.
Yes. Oh my goodness. Yes. And I have found that you get to that level because you pause and take time with the people, with the team that's doing the work. And by showing that you care enough to help them remove obstacles that they trip on every day, they re-engage with the organization, and it serves everyone. It makes everyone get to a better place, including obviously patients. So we might move to the next slide. We've talked through tiered huddles and problem solving and the huddle board, which we're going to speak more about the huddle board and metrics and how IT helped us out to the ends of the earth on this project. But I do want to touch base on leader engagement because sometimes I hear, hey, DMS, it's a grassroots, it's ground up. And that's a tough way to go. And so, Doug, your organization really leaned in with your executive team, and I think that made an enormous difference with this project.
Yeah, DMS requires executive alignment, period. And that's because it's hard. It's hard, I think, in part because it requires everyone to come into work and do something different than they did the day before. And it requires discipline to commit to standard work, especially on the part of leaders. So leaders who have achieved success, right? Today, they're managers, directors, vice presidents in healthcare organizations, and they've gotten a career's worth of positive reinforcement and positive feedback about the way they do things, all of a sudden are asked to do things differently. It's uncomfortable. They can feel unprepared. And frankly, the things we're asking them to do, they're not as good at as what they've always done before. And so nationally, you see high profile examples that include Intermountain Health with former CEO Mark Harrison publishing a description of their tiered huddle system in the Harvard Business Review back, I think, in 2018. In Massachusetts, under CEO Eric Dixon, UMass has made a commitment to daily management for over 9 years. Signature Health in Brockton had a rigorous daily management system focused on patient safety for the past decade under former CEO Kim Holland. And the new regime at Tufts Medicine has also made the commitment, hiring Lee Erickson, one of the most successful physician leaders of daily management in the country, as their chief quality officer. So I think it's no accident that you see those visible high-level leaders and organizations in places where this is actually working and people are achieving the outcomes intended in terms of reliability and better safety outcomes.
Yes, I love
Just
this. Go ahead, Denny.
just a question to both of you and a comment. We know from looking at, and Doug, you cited some of the work that's been done in other organizations. We also know in looking across the industry and in some recent reports that, over a third of staff think that information doesn't get passed on during shift handoffs. The things that they bump into, it becomes death by 1,000 cuts, right? They keep bumping into these things. People don't pick them up. And the question part of this is, do you see this, and are these huddles helping to address that? And the comment is, having management as uncomfortable as staff with change must be a very positive experience for the people on the line, because they know that they're in this, everybody's uncomfortable and they're learning to do something different. And that must be gratifying for people who are on the line, people in the units, people who are, right up front with patient care, right up front with facilities management, right up front with supply chain management, to know that this thing that they have to do every day now, that is part of the ongoing new work of the organization, is just as uncomfortable for the higher ups as it is for them. Can you tell us a little first about, do you see a drop in those kinds of trouble, those kind of poor handoffs that we've seen before? And is this a binding or bonding experience for staff and executives when it comes to the change that's asked of both of them?
Lainie, I've been doing most of the talking here, and you've got experience in many different organizations making this change happen. So I want to defer to you and get some of your knowledge out to the crowd here.
Yes, absolutely. I think maybe let's skip over to slide 10. And we can come back. We'll come back. Thanks for rolling with us here. So one more. Oh, my slide numbers are different. One more. Going to slide 11. There we go. Thank you. Oops, back up. So the tier 1. So here's an example of a tier 1 huddle board, and how we have seen this help shift between shift is the information is right here on the board. And as part of the huddle, you go through this information and you think, oh my gosh, these people must stand in front of this board for 45 minutes. Actually, you get really quick at it. Most huddles last between 6 to 8 minutes. And that's not the first week. It takes a little bit to get staff into the routine of, this is how we talk about it. We don't problem solve at the huddle board, because then obviously it would take a long time. But we do track the problems, and then we can see the trends. So if the shift handoff information isn't happening, or if there's not enough time, or we don't have enough staff to do the shift handoffs correctly, or there's charting going on when shift handoff should be happening, that comes up on the huddle board, and we're able to problem solve it at a different time. The problem solving does take energy offline. So you can't expect staff to continue their work that they do every day, all shift, taking care of patients, and solve some of these long-standing problems. So usually we need to pull off a couple of people, and that's where Doug's team with their service excellence group is fantastic because they know how to problem solve. They know how to take 30 minutes with a group of people and get to the root cause and come up with an experiment to move on to the next part of the learning, okay, why isn't this working? And of course, working with frontline staff, but also leadership. And then I also, and if I didn't answer that question well enough, we can certainly come back to it. But I did want to talk a little about how Doug was saying, you know, this is hard and it's different than what leaders have done before. And it's hard in a way that you wouldn't think it's hard. We have grown up in a way, most leaders have grown up always having the answer, always firefighting, always knowing what to do next. And daily management system requires the exact opposite. Humble inquiry, listening, not having the answer, because we can't have the answer. We don't do the work every day. So it's asking questions to help the team come up with the next best step. And that is the switch. Also, the switch is leaders must be in the workspace. They have to be in the hallways. They can't be in the office. They need to be out on the floor talking to people. Daily management system has done a really interesting maneuver on the hierarchy that's found in hospitals. So it kind of pulls at the web of, it goes like this, and instead we're all team, we're working together to do what's best for our patients. Did that answer your question?
I would just add, Denny, that yes, emphatically, it has helped fill those gaps. So we have issues that have come up onto boards like this about the handoff between the patient coming from the emergency room to the floor. We've seen that happen on more than one unit. It goes up to a tier 2 who recognizes that. This particular issue actually rose to a tier 3. A project team was assigned, and there was more accountability for the handoff process that already exists, but we're not highly reliable at yet, right? And that's part of this, is so much of this is an accountability system. So on the particular floor that this board represents, there was a commitment and a expectation that at 10 o'clock at night, the cross-covering physicians would come and round with the nursing staff on the patients who were there. After that commitment was made a few months later, some of the folks on a cross-cover, different shifts, on a weekend shift, weren't showing up. And so that appeared on this board. Once it appears on this board, you can see there's a resolve by date and there's a name. And so it got the medical director's name got put on it, and that created an accountability so that those rounds quickly resumed. There was accountability for that safety process, and these are all brought up as safety issues by staff.
Thank you.
Also, on this board, you'll see the S and the E. S is for safety and E is for engagement. And we, it depends on the hospital, but you choose the metrics that are going to make the most difference for the team. And usually in a nursing unit or in a or say lab or say pharmacy, if you have a lot of different labs, pharmacies, or a lot of different nursing units, we try to keep the metrics somewhat similar because it's easier to track and you get the momentum of the full team working on problems. So with safety, I know for a long time, Doug, your teams were tracking falls because that's always a problem with healthcare and patients in nursing units. And so, of course, falls, there's a lot to that, bed alarms, socks, rails on beds, getting people up and ambulating and into the restroom and back. And so tracking what exactly was the failure point on each unit with every fall allowed many of Doug's units to, or they're not all your units, many of the Baystate team. It's like, no, please no. Doug's team were able to make changes because of how we track the data. And those graphs down there on the left-hand side, which look a little tedious, but believe it or not, staff do get used to and enjoy writing the data up there because they know then it will get solved. If I have the data, I can get someone to help me move this along. And these are professionals. I mean, the frontline team, they know what they do. We're not working with folks that or, just came out of the 8th grade, they have many years of education and teamwork and professionalism about them, and they do want help. So they will collect the data to help resolve their problems.
So I'll just clarify, the right side of the board that you see is really about the escalations. And the left side with the S and the E really represents the visible learning and improvement and the demonstration of, can we standardize a single process every time for every patient? And so the safety metric that was started with early that relates to the outcome of falls was, do 100% of the time patients who are at high risk for falls have a bed alarm on the bed and turned on? Because it was noticed that there's lots of, patient goes down for a CT scan, comes back to the floor, someone forgets to turn on the bed alarm, or attach it back on when they were on a different stretcher, or they get moved, or it gets inadvertently turned off. And so they went through an audit process. You can see the black would indicate that there was no measurement. There was nobody there who was high risk, let's say. The green represents 100% of the time today. They were on, and they were on the bed and turned on, and the red means we had misses. And then whenever there's misses, there's a requirement to write down what was the reason why. So we start thinking about causes and root causes and countermeasures, and how do we standardize the process. And what you see over time is that what starts out as a lot of red dots for a given day, Lisa and her team constantly remind folks, red is good. We're not interested in picking things that we're good at already. We want to work on things that matter, that we're not good at, and become good at them. And then you see over time, some teams quicker than others are able to move that to mostly green every day. And again, our goal is, can we standardize the process? Can we get it right every time for every patient, and learn how to do that? And then how many things can we do that for?
Really well said. Thanks, Doug. Let's go to the next slide, because I do want to get to tier 3 and tier 4 and the magic that you are creating with those tiers. So here's another example of tier 1s. Of course, this is nursing examples. And so huddles happen every 12 hours at shift change. Other organizations have done this different, and it depends perhaps on the work area. So if you are in revenue cycle, probably meeting once a day is sufficient, but DMS has no boundaries. It's happy to go anywhere. So we definitely use it in Rev Cycle is fantastic for DMS, labs and pharmacies really, really well. And yes, we've actually even used it with like strategy folks to keep the strategy and marketing going the right direction. So we can go anywhere. So, and sometimes the boards don't fit. We do use just plain old whiteboards. So you'll see in the bottom left there, we had to do some creativity to get everything in the right place. But we do like to follow a standard, because that way, when leaders are walking around on the floors, they do know to look on the right-hand side to see if escalations are going the way they need to and how they can help. And then on the left-hand side, are we getting the metrics, or are we making progress? Or and then they can compare areas like, oh, this unit's having the same problem as that unit. I'm going to connect the leaders. Or, oh, looks like we're having this systematic issue with tubing across. Like, oh, I'm going to go look at that and see what's going on. So that's examples of just the tier 1 boards. And again, why I appreciate this DMS process is because the staff, they're engaged, they're in. This is not something that's difficult for them. It's more difficult for the leadership team. So then the next slide talks about tier 2, or looks at a tier 2 huddle board. And this is where anything from a tier 1 would roll up to that director or manager of those 3 or 4 or 5, depends on how many tier 1s. This poor Deb, her office was a little cramped, but it was good, nice and cozy and comfy. It was later stages of COVID, as you can tell, because we are awful close to each other. Doug, would you add anything to tier 2 before we head into tier 3?
It's the analogous process, and each of the different units and each of the people you see there around the board is a nurse manager for one of the medicine units in the hospital, and they would bring forward their collective data all the way on the left. They would have operational data all the way on the right, and then they would bring forward in the middle the things from the escalation board that couldn't be resolved at tier 1, so that then leaders had to work with other leaders across the institution to solve them here. And just having a place to take those things is absolutely incredible. So I can't resist telling you another story. So we did this within social work and case management, and the social workers have a tier 1 huddle, the case managers have a tier 1 huddle, they report to the same director, where there's a tier 2. So the social workers called out that in the offices that they were working out on the units, they couldn't call out long distance. So they would need privacy for sort of a delicate conversation, and they would be forced to go out to the nurse's station where they could get a long distance line. And this has been going on for years, and they just worked around it. Well, they brought it up because they had a forum to do that. It went up to tier 2. We talked to our IT colleagues who came in and gave them those long distance lines in their offices, and they could have the right conversation in the right place for their patients. Similarly, those phones that they were working had no caller ID. So one of the social workers told the story that they were on a call waiting to hear back from protective services for direction on an elder abuse case. And they took another call, but while that was happening, they got call buzzed in, and they left the call they were on that was important, and it turned out not to be protective services, but it turned out to be a family complaining about an issue that interrupted their workflow, and again had the potential for them to miss the important call that they needed to take to get someone the help they needed right away. So now they all have caller ID on the phones, which improves the efficiency of their workflow and prevents really important delays in care from happening. So that's just a couple of real life examples of, tier 2 being a place that things can get solved.
And I love that. That sounds so simple. Like, oh, well, why didn't we do that a long time ago? And there is so much of that in healthcare. There's so much of why didn't we do that so long ago? Because we didn't listen, and we didn't know that was that big of a problem. So the metrics that are tracked at tier 2 do go up to tier 3. Because the way DMS works is at the highest level of the organization, whatever the strategy is, whatever goals you're trying to get completed this year, 3 years, 5 years, longer sometimes, but that's sometimes a reach. Whatever those goals are, the executive leadership team gets clear on them. And then we cascade those metrics down throughout the organization. So as Doug said, with Baystate, safety, a critical area where they wanted to see improvement. So they would cascade the safety metrics down through the organization. So at tier 3 is our first place where we start to see the conglomerate, where all the information starts to come together about the metrics. So if you go to the next slide.
Lainie and Doug, we have a question from Lisa, who says, Doug, could you please share how you're including providers in the tier 2 huddles?
Yeah, lots of healthcare organizations really struggle with the idea that nurses have one rhythm of the day, physicians have a different rhythm of the day, and how do we harmonize those rhythms? Some of what we do is asynchronous, and some of what we do really requires that in the moment collaboration. And so for every physician on those floors taking care of patients, we don't require that they come to the tier 1 huddle, because they're doing other things at that time, and they're looking at patient information, they're visiting patients in their rooms, other things. But the tier 2s, we have set a standard at Baystate that there are certain physicians with leadership roles in different services that really need to participate, be present, bring their own data for shared visibility and awareness, and that's what we've done at the tier 2 level. Thank you.
Oh, thank you. We also, there are some similarities between the huddle concept for DMS and scrums in agile development in organizations that are looking to get better, faster, more effective by getting smaller and more agile and more immediate. Could you talk a little bit about those parallels? I mean, Doug, you referenced some people who were industry experts. For those of us who are in technology, this sounds great to us. It sounds familiar. It sounds, you know, much like how work is changing in order to deal with complexity. Could you talk a little bit about that?
Lainie, do you want to start?
Sure. Yes, absolutely. I love agile in healthcare it's almost an oxymoron, but it's becoming very, it's not in IT, obviously, with healthcare, but the rest of the organization is right behind IT on this one. We're not leading out in front. So definitely with the problem solving with the agile methodology, that plan, do, check, act cycle moves very quickly. The opportunity we often run into, and you can see it in what we've shared so far, tier 1 and tier 2 are very manual. They're whiteboards. We haven't figured out the IT mechanisms yet, and maybe we don't need to make some of those processes simpler, because it's really the collaboration, the people, the eyeballs on eyeballs and not on a computer screen that makes the magic work with that. But with tier 3 and tier 4, and especially having to go virtual with huddles, that required a lot of scrum work to figure out how to get those in place. How do we make a system? Which IT solution are we going to use? That one didn't work. Let's try this one. That one didn't work. How are we going to get all these people on telecom? Or nope, that didn't work. And quickly being okay with it. And Denny, I think you said it earlier, that it's okay. It's going to be messy. Everybody knows it's messy. And we all just come to the table going, who knows if this is going to work? And there's no preconceived, idyllic, this is how we should be. We're not doing it. Everyone's going to feel bad. It's like, no, this is iterative. We are going to rock and roll through this. Sometimes we're going to trip and we'll help each other up. And then we'll show up the next day and say, okay, let's see how it goes today. And then Doug, I definitely want to touch on the method that your IT team came up with, the dashboards.
Yeah, I'll address Denny's question. Denny saw me smiling when he asked this question, and there's a few reasons for that. You know, one is folks around here know I really don't like business jargon, right? So this is a fairly standard lean management system approach, but I often tell people I don't speak Japanese, and you know the reason for that is that I've seen nurses and physicians get turned off by the jargon, and so we really try to call things what they are and stay away from the jargon. So within our Center for Analytics, we have been working with an outside group to help us learn agile methodology. And ironically, in order to create the tier 3 dashboards and the tier 4 dashboards, we've tried to create a Center for Analytics and Operations Excellence data analytic pod with using some agile methodology. So we tried to stand up the tier 3 boards in sort of a 6-week time period, using agile methodology, and you know, Scrum and Scrum Master are some of those jargon words I hate, but I'm partly smiling because when I sit and it's my turn to facilitate the hospital-wide tier 3 huddle with 75 people on it and work through the board in a quick way and make decisions on the fly about, is that something that just got brought up that we need to hear about later today because it's so important, or we can put on a 1-week list with accountability for somebody. I feel like the Scrum Master.
Mm-hmm.
And there's some jargon you simply can't avoid. You know, it's you can try, but the effort expended at trying to avoid some of these terms is almost worse than having to use them. But thank you for that. I think, Lainie, you said something that was very interesting, which is, you know, maybe we do this with IT, maybe we don't, you know, and I think there's, you know, we have a lot of technology, but sometimes technology, as much as it might create efficiencies, creates distance, and it loses immediacy. And especially, I would think, in the COVID crisis, one of the things that would be attractive to prospective staff joining a health system and working with colleagues on the floor is they get the chance to actually work together and do what people have done for a long time. Mm-hmm. Technology is in our lives to such a significant or substantial degree that having processes that are somewhat independent of it, we all rely on it to a degree, but somewhat independent, I think probably is refreshing for some folks. You know, it's a chance to break out of the torpor that staring at a screen can bring, and kind of, you know, hash it out with your colleagues. And I think that would be a morale builder and a collegiality builder.
Yes, absolutely. It absolutely is. At the end of the day, we are people, and some of us don't like people as much as others, but you know, at the end of the day, we do like a little bit of, you know, face contact. And you know, the other part of this DMS board, you'll see it on the right-hand side behind these two ladies, where it says department up at the top, and it has SPESS in columns and really big magnets. DMS is fun because you move magnets around. There's this childlike piece of it where you can show, oh, I'm red, and it's kind of fun to be red, or I'm green, and it's kind of fun to be green, because I can move my magnet around it and report out on that. So there's this real elementary aspect to DMS. But then the IT part, which is the next slide, which is what helps leaders lead the organization, which helps leaders realize where they need to lean in, what is at their level to go check out, either by going to the front line and saying, okay, look, what's going on in this area with our ED borders? I need to go check this out. Or what's going on over here with our extended length of stay? Oh, this is not doing what we need it to do. So the C4A, the Center for Analytics team, put this dashboard together, and I don't know which version this one is. I mean, this guy has gone through so many iterations. It's amazing.
I think it's about number 3, and we're actively planning for the changes for version 4. It's just what you described, Lainie. It's let's sit down with our INT colleagues, let's help them understand what we're trying to do, and let's understand where the data sources are for the information we'd like to share for a shared mental model of the entire team in the hospital on a given day, based on the current issues. And as you know, it's not hard to see from this dashboard that the current issues are capacity management, backups in the emergency department, difficulty discharging patients to post-acute care and getting them out of the hospital, and COVID cases in-house. And so that was the initial focus. Well, this is not where we want to end up, right? We want to get to, well, there's issues in ambulatory care with access. There's issues in the OR with timing and numbers of cases and how things are going. So we worked with this for a while. The team that participates, and again, trying to use some user information, trying to go to the users in the front line who are the leaders who need to see this information. What would be most helpful for you? How would you like to see the data? And then our operations excellence team collected that data through interviews and focus groups, sent out a survey to prioritize them, and they're very near a finalized list of the next version of this. They're staying very close to our Center for Analytics colleagues on that pod. And I expect very, very quickly, within a matter of weeks, we'll be at the next iteration, which will be more useful than the last. And as Lainie said, we'll change it again as we need to.
Yeah, I think the interesting part for me in watching this dashboard come together was defining the data points and the time of day that we wanted each of these things to happen, and pulling it. It doesn't all come, I'm talking to people that already know this. This information doesn't all come from one happy little database that's all organized and in line with the rows on its head. It just doesn't. It's this, the data lake. I will be forever scared of data lakes after being here, because it's not consistent. It's not pulled correctly. We don't manually track it right, so it doesn't get in the system right. Do you want it at midnight? Do you want it at midnight 01? Do you want it to roll? Do you want it to continue to accumulate? Or do you want just the snapshot of this 12-hour period? And I really did appreciate the IT team, because they listened. They asked questions, and we'd give them this kind of clear answer, and then they'd ask another question. And actually, operations, we realized, wow, we do not know what we're asking for. So it was a great exercise in collaboration. I'm sure Some of the IT guys had to go to therapy, as did the operational people, because it was just difficult to find the right space for, oh yeah, that is the data we need. So hands off to the C4A people that hung in there with us.
A question we have from David is, do you have staff physicians, hospitalists who are brought into the process and participate in the huddles? I mean, we have, physicians who are the admitting physicians who might be checking on their patients, but increasingly hospitalists do this work. How do you address physician engagement with these improvements and what it means for them as far as the process is concerned?
So fantastic question. Thank you, David. I think we had conversations initially about, do we try to get the doctors on the unit to come to the tier 1 huddle? We decided no, most organizations don't do that. That harmonizing those rhythms wasn't going to work. Then we said mandatory tier 2 has to have a leader. So we've got one of the hospital medicine medical directors that participates in the tier 2 for the medicine floors. We have a medical director in surgery who participates in the surgical floors. So tier 2s have physician leaders usually at the medical director level. Tier 3, and again, this is where executive leadership comes in. Our chief physician executive, my colleague Andy Artenstein, because we held hands as a leadership group that we were going to do this, basically, required all of our department chairs and service line leaders, the most senior physicians in the organization, all attend our tier 3 huddle at Baystate Medical Center. And the chief medical officers in each of the community hospitals are represented and participate in the tier 3 huddle at each of those regional hospitals. So that makes a huge difference, right? So when tier 1 issues come up that relate to physician performance or collaboration and teamwork, where we need a physician to be part of the solution, it's very visible when on the tier 3 huddle, the person's name next to the solution is our hospital medicine director or our chair of our service line leader for neurosciences. That's happened, and that lets everybody know we're all in it together. Not every frontline physician, but physician participation at tier 2, tier 3, tier 4 level, and it's very visible and it's very obvious. And I don't think we can be successful without that.
Mm-hmm. Yeah, absolutely. Provider engagement is critical with daily management system, because there's some of the strongest leaders are the providers, and they have the opportunity to move around in the hospital and interact with a lot of different departments and systems. So listening to what providers are experiencing is very important, as it is for providers to understand the other side of the house, supply chain and the rest of it. Some hospitals do stand up a hospitalist tier 2 or a tier 1 or a huddle of some sort, where it's just the hospitalists that come together. It's usually virtual, and where they just run down, here's the issues that I'm having. I put my orders in, they're not done on time on whatever unit. Meds weren't delivered on time last night because of this, that, or the other thing. That MRI is down again. I couldn't get my patient in overnight. Or it's 4 o'clock. We thought we'd have them in the OR by now, but I'm still trying to, all the things, because they are often the crosswalks between the different divisions and the departments, because they see it. So having the hospitalists have a huddle at some point during the day, it's hard sometimes to figure out where that is, because rounding, and it's usually around 2 in the afternoon-ish, that works for them. And having their issues also, it usually goes from that huddle to tier 3, because it's easier to get it's hard to get a tier 3 for physicians, has been my experience. Although I'm sure there's an organization that has done it, because there are a lot of experiments going on. Great question. I agree. Yes, please pull in your providers. They are very important. Let's move to the next slide. And this is the tier 4. So we probably should have given a better idea of Baystate and how many hospitals there are and how many tier 3s there are, and how this tier 4 plays in. But tier 3, that last one you just looked at, was for Baystate Medical Center, which is the primary hospital. And then there are other hospitals that also have that tier 3. Similar, it looks the same. So you could go, anyone's always welcome to go to any huddle at any time. They're not exclusive clubs. You can just show up wearing whatever you're wearing. Life is good. But everything does roll up to this tier 4 board, which uses, as you can see here, additional technology, thanks to our brilliant IT team. Doug, do you want to review this one?
Yeah, sure. So we have this meeting as a group of senior vice presidents. The leader of the tier 4 is our executive vice president, COO for the health system. And we invite ambulatory leaders as well as human resources to participate in this. This is really a place that when we get mature, we're not just going to use tier 4 for situational awareness and for escalations, but we're really going to be having some quick discussions that help us drive strategy, and we're going to be able to follow using the data whether we're achieving the ends we've intended with our strategies. And we're not there yet. Many organizations are not. We need to come together as a team. We need to hear the escalations. We need to gain, I think, confidence in working together as a team, right? Some of the issues with tier 4s in other organizations are about leaders worrying about stepping on each other's toes and really getting comfortable with all-out transparency and accountability to each other and forgiving each other and all of that. And I think we're in that process, which is great. But the starting point is those escalations. So we've been having these backups in capacity and, in the emergency department, and we've been trying to solve them at the tier 3 ED level. We've seen the tier 4 team basically make decisions like we are going to take patients from one hospital and move them to another because this is an emergency and needs to be taken care of right now. So using the resources of the whole system. And then we've also seen the tier 4 escalate beyond and ask our health system CEO to advocate at the state level for things that we can't control even within our health system. And so, I think it's been really great for visibility and understanding on the part of the senior vice presidents from different parts of the organization, what's happening each day and what is happening in someone else's part of the organization. It's been great for, tier 4 taking an escalation from tier 3 and sending it back down and saying, hey, we did something about it. So that's been fantastic. And then we've also, as I said, recognized when we needed to escalate this beyond ourselves, and it was partly out of the control of the health system.
Mm-hmm. Mm-hmm. Well said. Yes.
Well, this is a great example of going from the situational awareness and fix the problems in real time that we see at tier 1 and at tier 2 to broader operational changes that we see at tier 3 to organizational, strategic and business-wide decisions that need to be made. So there's less of a top-down, to use jargon, less of a sort of an executive-led strategy process and more of a staff-informed strategic process where staff get to see that some of these problems that are intractable required big solutions, and that big solutions were that management wasn't afraid to look at them or wasn't averse to looking at them and did something about them, which I think is again part of building that kind of esprit de corps that people want in a health system. You're a big place. You're one of the largest health systems in the state, and you have, if not the largest, the second largest ED in the state. It's a chaotic environment. So to see this kind of discipline, brought to bear on a complex, chaotic academic health system environment, multi-site environment, is really encouraging. I think this is a great advancement for the industry to rather than trying to figure out within the executive suite what needs to be done, is and trying to read the tea leaves is actually having that information come up from where it's actually happening. So
Yes.
congratulations on that.
Yes, they have done an amazing job. The executive leadership team being aligned makes a huge difference. The collaboration with the IT folks, amazing. And then of course, OE, those internal experts that are on the floor every day helping people learn. It's the perfect setup. And the no stop, can do attitude that I just kind of think comes with Massachusetts. I don't know where you guys get it. It must be the cold. You're just like, yeah, that was hard. Let's do it again. Okay.
We're just cranky Puritans. That's all. You know, we want to fix things that are broken.
Yes, it's so true. Let's go to the next slide because it shows additional IT involvement. So how huddles have to be virtual. So as you said, Baystate's large. We can't get everybody in the room. So we had to come up and do a virtual huddle. And the first few weeks of this, or I don't know if it was weeks, it was like probably 8 days, a little rocky, you know, because you're not used to raising your hand or not raising your hand, or can I talk or can I not talk, or you are talking too long, because now we're all listening to, okay. So getting the rhythm in place took a little bit of time, and then also using the spreadsheet on the right-hand side to track issues and status across the organization. It took some discipline and some guidelines and rules to follow, and some really great folks that could speak while other people manage the IT and other people manage typing into the Excel spreadsheet. But I think it has worked. We were like, this spreadsheet's probably not going to work. We're going to move to something else really quickly, but it seems to be kind of bumping along.
It's working very well, actually. It's more than bumping along. I think that this is our tier 3 huddle at Baystate Medical Center. As you said, Denny, we're a fairly large, complex place, and we've got usually on a given day 75 to 80 people on this tier 3 huddle virtually.
So the tier 1s and tier 2s are like in person,
yes,
on the line. But when you get to tier 3 and you need to look at organization, it's just issues that are or need to be addressed organization wide. That's when you start to combine, you know, the in-person and the visual. Is that right? In-person and digital.
We have some tier 2s that are virtual, and that's really about distance and efficiency. But most of the tier 1s and tier 2s are in person.
Okay, thank you.
And then I think I saw a question about staffing and budgetary opportunities when problems run into that. And so maybe if we could go back up to, I think it's slide 8, I'm gonna guess because my slide numbers are wrong. The one we missed, that one. Whoop, back down. Yes, no, that one, yes. One with the circles. So staffing and budgetary issues, of course, happen in organizations. So tier 1, there are staffing opportunities. And so usually we encourage folks to try to work through the staffing issue at their tier 1 level. Can they flex, do anything? What can they do? And if they can't do it, then of course it moves up to tier 2, where there's more flexibility, perhaps of pulling in across units or using resource nurses or whatever, PCs, whatever you're looking for. At tier 3, that's when you start to feel the pain of, no, really, we don't have enough staff for the ED this evening, or no, really, we don't have enough staff. We have the ICU beds, but we don't have the staff for the beds. And tier 4 is across the system. We have staffing opportunities, or what are we going to do with it? Or we can't afford to pay for those expensive staff that are available, but it's going to run us out into the street without dinner. So each organization, I think, is working through across the nation how to deal with the staffing situation and the budgeting. I think where daily management system comes in is it forces the conversation, and it doesn't leave the problem at the front line. So it brings the problem to the executives, which are the ones that need to help fix it when it gets that far. So it forces the conversation, which is fantastic. And then it gets creative. People start getting creative about how to address this. And I know, Doug, you have some ideas from Baystate's experience. What I saw at another hospital was an experiment where they were down staff, and it's still in place. They thought it would just be a COVID opportunity and census was so high, but it has stayed in place and it's actually working, where they decided to ask folks that were not clinical. So they were in OE, they were in finance, they were in HR, if they would be willing and be paid to partner with someone in any of the clinical areas, whether it's lab, pharmacy, just any of the areas where they were down staff. And they could do as much or as little as they wanted, as much as they were able to manage with their manager, and not have it be a strain or a concern or regulatory issues. And many folks said, yeah, I will take a shift every week happily. I'll take a night shift happily every week and then stay home with my kids during the day. And they've kept that going, which I didn't think it was going to work, but I appreciated that this was a tier 3 idea that they decided to experiment and give it a go. And turns out it worked. There's been a lot of other things that haven't worked, but that was one of the ones that did work. And Jenny, we might need to re-ask the question because I only caught it quick and I'm not sure I'm answering.
Yeah, I've got it, Lainie. Thank you.
Okay.
David, great question, right? So as was said, there are massive challenges in healthcare delivery systems right now. And there are financial challenges and staffing challenges and supply challenges, and daily management system is not, a magic wand, right? We still have to manage the business. What this does is, as Lainie said, it creates visibility up and down the organization for which parts of the organization on a literally daily basis are short. So if we know that the demand is starting to back up in the ED and we have more borders where the waiting room is filling up, we can act sooner. We can make different choices about where to redeploy staff or where to share staff. We can run experiments and sort of say, okay, it's really bad here. What's the better of 2 options? Let's try it out today and then circle back tomorrow and see what worked. And then that becomes the norm. As Lainie said, we've done all the things that Lainie described when things got really backed up in a surge of respiratory issues. We've seen incredible flexibility and adjustments happen that I am sure are happening more because everybody's aware of where the pain points are and people are jumping in to help. So we've redeployed non-clinical nursing staff to go to the ED, or our patient experience staff have gone down to the ED when it's been extremely busy, and they've restocked the carts and the supplies and certain things. And that has been visible evidence that when we raised this out of tier 1, someone listened and it made our life better, even though we don't have 10 more nurses that we can't find, right? And then that leads to different decisions at tier 4. At tier 4, when you're bombarded on a weekly basis by hearing where all those different things are, I guarantee you in the budget that we just put to bed for FY23, there are richer nursing staffing ratios than there would have been in past years because of this process and because all of the senior leaders sitting around the budget table feel acutely where the pain is.
Mm-hmm.
One of the big challenges that you and other health systems face, among those challenges are those that are extrinsic to your organization, discharge planning being extremely difficult. How do you place patients in post-acute care when post-acute care is suffering the same problems that we're seeing in the health system itself? Are you looking at engaging post-acute partners, other parts of the extended delivery system, if you will, in this kind of process? Because there's a lot of great work that can be done to improve things internally, but sometimes you bump up against the constraints that no amount of internal work is going to solve. There has to be, some loosening of the strictures and some, redesign of the processes and some commitment of resources to providers outside the health system who keep things moving and keep the flow of patients moving. Could you talk a little bit about that?
So one of the real challenges relates to behavioral health and the lack of both inpatient behavioral health resources, but also crisis resources and drop-in places to get some respite care and address issues. So when the ED gets busy, we rely on state mandated partners to come in and do crisis evaluations for us. And again, as we start doing this daily management system work, as we start getting visibility for what number of behavioral health boarders are sitting in the ED and not and waiting for too long, our problem solving kicks in. And we find that they're short-staffed as well. And we find that the people who come in to do the crisis evaluations can use accountability too, right? And we can partner with them better to sort of say, I need you to do this one before you do this one. Don't just do the last one that came in, because we can move this one faster. So as a result, we created a completely different partnership with those people who come in to do crisis management and RED, crisis evaluations. We created visibility between the two organizations and transparency for how many were on the list, were they being managed, were they being followed as stipulated in the contract with our partners. And we even had our program director of behavioral health go out, get the CEO of the organization to come in and walk through our ED and see what we were dealing with, which created incentive and motivated change on their part. So I would argue that that's an example of how the principles of daily management really extended out to the way we interacted with our partners and not just what we did within the walls.
That's a great example. Also, I've seen at the various levels, the leaders start to pull in who they need in their huddles. So tier 2 pharmacies often ask their suppliers to join. It's virtual, of course, on the phone or the computer. Like McKesson is present in understanding because there's shortages. In some ways, the pandemic did help us out a bit because it forced us to have conversations and doesn't just show up. We need to interact with each other. Another example is EMS attending tier 1s. So we bring somebody in, the system's not going well. So we understand, or like the patient transfer doesn't happen, but there's not a room. We got our people standing around. So having the EMS representative at the tier 1 huddles and ED, really super helpful. And then another example from a hospital is at the tier 4 level. There is a large pediatric clinic system that is separate from the hospital, but this hospital had the inpatient aspect of peds. So at their tier 4, they included the CEO and with COO and CNO from the large pediatric clinic organization, just to help with flow and maintain communication. So yes, there's a great need to pull in others. It's a great question, Denny. Thank you.
Welcome. Thank you.
And I'm watching the clock here. I'm having too much fun. We started this. Doug and I said we could talk about this all day, and Denny's like, "Okay, please, not that."
I've got a couple of things that maybe I'd like to at least leave with folks, and one is that this is all about learning, right? The point of creating this daily management system is to create learning organization. It's to create continuous improvement and learning throughout the organization. And while we grab people with the escalations, with the chance to bring things that are a problem to them up and someone will react to them, and we grab them by recognizing great catches and inspiring people to do patient safety work and go above and beyond, we then very quickly mature into how do we standardize a process, get little things done every day for every patient on every shift, and get those high reliability principles and practices going. And the only reason we're doing that is to change outcomes. And that's the maturity. So when we learn how to do the evidence-based bundle for preventing infections on 6 different floors the same way in a reliable way every time, and we see the number of infections go down, that's really what this is all about. And I think can't emphasize enough that it requires a structure. It requires experts in your organization. It requires a culture shift and a willingness as leaders to commit to this and to get uncomfortable and to change what you do when you come to work every day. So there's a cultural change. But one of the things that we try to never forget is that this is about learning. This is about learning at every level of the organization. This is about teams at the front line learning. This is about leaders learning. And this is about creating a continuous improvement environment.
Yes, Doug, well said. Very, very well said. And I think that the collaboration between people and the trust that's developed through this daily management system between people is probably the foundation for our next chapter for healthcare, which is where we really do need to go. We are well aware that it doesn't work the way it is working now, and that it's not going to be a silver bullet that comes through and that's an ironic use, huh? A silver bullet is going to save us. Usually bullets don't do that. So I appreciate that.
They only hurt us if we're vampires or werewolves or something like that.
That's
Otherwise,
right.
we're fine. Not that I'm going to put myself on the line and test that hypothesis, but yeah.
Good point. Thank you. Yeah, so I appreciate the work that Baystate has done. It's really been amazing. They've leaned in and covered more ground in fewer months than any other organization I've worked with before. And it's very exciting because it helps all of us. When one organization learns and is willing to be humble and move forward, it helps all organizations. So kudos to the team. And thanks, Denny, also for letting us be here today and tell part of our story.
Well, we're delighted to have you. And we want to thank both of you for joining us. I'm going to fire one, maybe 2 quick questions at you before we wrap up. One is, if you could go back in time and give yourself advice at the beginning of the process, knowing what you know now, what advice would you give yourself?
So that's a hard one. I feel, again, extremely fortunate to work with the operations excellence team. We did a bunch of scenario planning. In fact, we started in December of last year, and we asked ourselves, should we start, or is the pandemic a bad time to start? And we said, there's no good time. We need to move forward. And boy, in retrospect, I'm so glad we made that decision. I think we've had our eyes open. We've understood the risks. One of the key things that we debated was, it's really important for this to be successful for each of the teams that participate in a Tier 1 huddle to understand the why, to really understand why we're doing what we're doing, so they can, fully commit to it. So, do we take people offline in a crisis situation and train them in classrooms before we start doing this, right? I've always felt like one of the biggest mistakes that organizations make in doing this is say, I want, huddle boards up on 20 units tomorrow and people start huddling, right? Mm-hmm. Well, we debated, but every single unit before they've come up has been on a 9-week cycle. All the teams have participated in choosing the metrics for their unit, and every member of the team has gone through a 3-hour set training session, so they really know what's going on. And I think I similarly look back and I think, we could quibble with some of the choices we made, but we made them with eyes wide open. And we did that because we had partners like Point B, and because we had the internal expertise with Lisa Demko and her team who've been through this before. And I think taking the time to have those robust discussions to assess what our risks were and to make the best choices we could at the time, being willing to stop and change course if needed, was really useful and helpful.
And lastly, flipping that question around and saying, looking forward rather than looking back, what are some of the things that you're excited about that you're going to be able to do now that you couldn't do before?
Oh, there are so many. So we are extremely focused on coaching leaders right now. We've realized that discomfort, that changing what you're doing. We need to walk people and hold their hands sometimes through changing what they do when they come in. And we're trying to be flexible as we do that, but we're redirecting some of the operations excellence team members' time towards a robust coaching program so that we identify where leaders are uncomfortable and we fill those gaps. To me, that attention is going to allow us across wide swaths of the organization to speak the same language, to partner on new innovations, and to get the outcomes we need to. This is all and always has been about safest, highest quality care. And really what we're looking towards, and we've started to see this happen on individual units that have gone 8 months without a central line bloodstream infection, or 9 months without a catheter-associated urinary tract infection, which seems to correlate with their ability to learn how to standardize a process. It's really the exciting part is getting those outcomes we want. It's reversing that patient safety trend I talked about that's happened nationally as a result of the stresses of COVID, and knowing, demonstrating, and visibly seeing the great care we're giving to our patients.
Well, Lainie, Conley, Point B, Doug Salvador, Baystate Health, I want to thank you both for a really terrific presentation. I just want to remind our audience and our folks listening to us on demand that we would like you to join us for an overview of our 2023 Executive Forum that we're going to be conducting on November 2nd at 3 p.m. The information to attend that is on your screen now. This used to be what we called the CIO Forum. And for many years, John Halamka from the BIDMC and Bill Fandrick, the Chief Information Officer of Blue Cross Blue Shield at the time, they led this forum. And it's been a forum we've kept going since 1997. We have a new agenda in 2023, which is the road to interoperability. And we're going to be bringing in industry experts, regulatory experts, locally, nationally, to come in and engage with us, not lead a presentation, but participate in a discussion. The idea being that a forum is a back and forth. A forum is an active conversation among all the people sitting at the table. So if you're interested in knowing what the road to interoperability looks like as addressed and understood by some of the best in the country and laid out in a curriculum over 12 monthly meetings that provide us everything from why bother to what this means for us going forward and what does information sharing and interoperability really mean, we encourage you to join us, and you can see that information on your screen. Lastly, as we wrap up, we'll have a brief survey on the screen that we ask you to complete for us. And again, Lainie, Doug, thank you so much for an outstanding presentation. I love this stuff. This is like people and data and transformation, and these are hard times. So seeing healthcare do and seeing Baystate do what you're accomplishing is really gratifying and pretty heroic. So congratulations on your work. Thanks everyone for joining us today. And with that, we're adjourned.
Thanks, Denny.
Thank you.
Thank you all.